Hello everyone, welcome back. This is Dr. Maitreyi. Today we will be learning about an important aspect in cardiology, which is your approach to tachyarrhythmias and supraventricular tachyarrhythmias. Okay, so let's begin. So what is tachycardia? Tachycardia is basically defined as a heart rate of more than 100 beats per minute. Okay, so tachycardia is basically defined as a heart rate of more than 100 beats per minute. So what is the classification? Based on the origin, this can be classified as a supraventricular tachycardia, junctional tachycardia and ventricular tachycardia. So based on the origin, it can be classified as a supraventricular, a junctional or a ventricular tachycardia. A supraventricular tachycardia means what? It can be from a single focus in the atrium or from multiple foci in the atrium. Okay. Then you have junctional tachycardias. Junctional tachycardias are those which arise in the AV node, and we have ventricular tachycardias where the focus is in the ventricle. Okay, supraventricular tachycardias can also include some re-entrant tachycardias. So, supraventricular tachycardias can also include some re-entrant tachycardias such as your AVRT and your AVNRT, which includes the presence of an accessory pathway in AVRT. So, supraventricular tachycardias can be your atrial tachycardias because it can be from single focus or multiple foci in the atrium, or even your re-entry which includes your AVNRT and your AVRT. We will be looking at each of it in detail as we move forward. Junctional tachycardia is when the atrium is not functioning. So, the focus is not from the atrium, it is at the junction of the atrium and the ventricle. Right? Ventricular tachycardias arise from the ventricle, and this can be a ventricular tachycardia or a ventricular fibrillation. Okay. Now let us look at the mechanisms of tachyarrhythmias. Okay. So what is the first mechanism? The first mechanism is that there is enhanced automaticity. Now you know that the electrical impulse is carried forward from the SA node to the AV node, then to the ventricles, right? So the SA node has an intrinsic rate, it has an intrinsic firing rate of around 60 beats per minute. Now if that intrinsic firing rate itself increases, then you can have enhanced automaticity. Similarly, there can be some other focus in the atrium which starts beating on its own. So this is what we mean by enhanced automaticity. Okay, so this can result in multiple tachycardias. So what are the examples? You have atrial tachycardia, junctional tachycardia and ventricular tachycardia are examples of enhanced automaticity. Okay, even the ventricle is capable of having enhanced automatic foci. Fine. Then we have triggered activity. The second mechanism in the tachycardias is your triggered activity. That means that there is a trigger. For example, this is your ventricular action potential. So what happens is that there is a trigger. Let us say that there is a premature complex. Whenever electrical activity arises other than the sinus rhythm, it arises prematurely, such as a premature ventricular complex, which is basically also called as an ectopic, So whenever you have a premature ventricular complex or an ectopic where there is some focus which is happening in the ventricle but it arises faster than the next expected sinus rhythm, if this falls in the phase 2, or phase 3, this is called as an early after depolarization. Okay, in your phase 2 or phase 3. And if there is an ectopic which falls in your phase 4, this is called as your delayed after depolarization. Delayed after depolarization. So, whenever there is an ectopic impulse which falls on any of these phases, what happens is that this can trigger a run of arrhythmia. This can trigger a run of arrhythmias, most commonly a ventricular tachycardia. Okay. So, what are the arrhythmias associated with early after depolarization? We have your long QT syndromes, hypoxia and hypokalemia. Okay. So, you have your long QT syndromes, hypoxia and hypokalemia, which are the arrhythmias associated with delayed after depolarization. You have your outflow tract VTs. LVOT and RVOT stands for outflow tract VTs. Outflow tract ventricular tachycardias. Okay. So, how is the RVOT-VT and LVOT-VT formed? It is because of delayed after depolarization. Alright, fine. Now, let us look at re-entry. The third mechanism is your re-entry. What is the meaning of re-entry? In a specific part of the tissue on the heart, in the specific part, what happens is that there is a re-entry circuit. That means it is an endless cycle. It goes round and causes simultaneous activation of multiple tissues. Fine. So, this can be classified as a macro re-entrant circuit and a micro re-entrant circuit. So, what is the study that we do to see the electrical activity of the heart? This is called as an EPS or an electrophysiological study. Okay, we do a electrophysiological study, right? So, on the electrophysiological study, if you are able to map the circuit, then it is called a macro re-entry circuit. This is called a macro re-entry circuit. If you are not able to map the circuit is very small, then it's called as a micro re-entry circuit. Okay. So, your AV re-entrant tachycardia, AVRT stands for atrioventricular tachycardia, re-entrant tachycardia. Okay, it's called your atrioventricular re-entrant tachycardia. Okay, or the presence of an atrial flutter. The presence of an atrial flutter are examples of macro re-entrant circuit. They can be mapped on an EPS study, whereas a micro re-entrant circuit is your AV node re-entrant tachycardia. That means the re-entry is within the AV node. Okay. So, what is the difference between AVNRT and AVRT? The re-entrant circuit, if it's within the AV node, then it is an AVNRT. If the circuit is between the atrium and the ventricle, as a large circuit between the atrium and the ventricle, it is called as an AV re-entry tachycardia. And atrial fibrillation is another example of a micro re-entrant circuit. Okay. So, let us just revise the mechanisms of arrhythmias. Okay. The first is your enhanced automaticity. Enhanced automaticity, as the name suggests, basically means that any part of the cardiac tissue starts beating at a higher rate and results in a tachycardia. So, examples are atrial tachycardia, ventricular tachycardias and junctional tachycardias. Then you have triggered activity. If there is an ectopic that falls in your phase 3 or your phase 4 of your action potential, it can trigger a run of VT. So, this is seen in your torsades de pointis, in your long QT syndromes and your outflow tract VTs. Fine. The third mechanism is a re-entry, which can be, so your macro re-entries are your AVRT and atrial flutter. Your micro re-entries are your AVNRT and atrial fibrillation. Okay. So, that is about your mechanisms of your tachyarrhythmias. So, let us understand a brief approach to tachycardia before dealing with each of the tachycardias separately. Okay, fine. So, how do you approach a tachycardia on the ECG? So, the first thing that you see is you look for the presence of P waves. We look for the presence of P waves. If each P wave is followed by a QRS complex, if each P wave is followed by a QRS complex, then this is called as a sinus tachycardia. This is called as a sinus tachycardia. So, if each P wave is followed by a QRS complex, it's called as a sinus tachycardia. Fine. Now, this can be of another type as well. Each P wave is followed by a QRS complex, but each P wave is of different morphology. Each P wave is of different morphology. What does that essentially mean? Now, what does that essentially mean? If this is the atrium, that means that there are multiple foci from which the tachycardia is originating. There are multiple foci from which tachycardia is originating. That is the reason why each of the P waves are of different morphologies. So, this is in your atrium. Okay. So, this is what we call as the multifocal atrial tachycardia. This is what we call as the multifocal atrial tachycardia or the MAT. Okay. So, just see this line diagram. You are seeing this P wave is of one morphology, this P wave is of another morphology, this P wave is of another morphology. This basically means that each of the P waves are arising from different portions in the atrium. Okay. So, this is what we call as the multifocal atrial tachycardia. Fine. So, let us just look at the ECG here. Can you see here? There are different morphologies for each P wave. Each P wave is of different morphology. And what do you feel the rhythm is? The rhythm is irregular. The rhythm is irregular. Okay, the rhythm is irregular. Fine. Okay. So, this is about your tachycardia when there are P waves, when P waves are present. Now, let us look at when the P waves are absent in the ECG. Now, if the P waves are absent in the ECG, you have to look at the QRS complex. You have to look at the QRS complex. So, if the P waves are absent in the ECG, you look at the QRS complex. Now, if the QRS complexes are narrow, you are dealing with most likely a supraventricular tachycardia. This is not always the rule. This is not always the rule. It just means that if you are dealing with a narrow QRS complex, it is most likely a supraventricular tachycardia. But there are always exceptions to the rule. So, if there is an SVT with aberrancy, what is the meaning of that? If there is an SVT with aberrancy, what is the meaning of that? The meaning is that the supraventricular tachycardia is associated with a bundle branch block. The supraventricular tachycardia is associated with a bundle branch block, then you can have a broad complex tachycardia. But that is something that is one level higher. Currently, you just remember that if there is a narrow complex, the QRS complex width is narrow, then you are dealing with a supraventricular tachycardia. Now, supraventricular tachycardias, you see whether rhythm is irregular. If the rhythm is irregular, what are the things that you have to see? If the P waves are absent and you see these kind of waves with an irregular rhythm, this is called your fibrillatory waves. Fibrillatory waves with an irregularly irregular rhythm, this is your atrial fibrillation. Okay. And if you see these kind of waves, what are these? These are your sawtooth waves. Sawtooth waves. Okay. These are your sawtooth waves and this is nothing but atrial flutter. This is nothing but your atrial flutter. Okay. So, let us look at these two ECGs. Can you see any discernible P waves? Can you see any discernible P waves? No. You can only see some fibrillatory waves and the rhythm, can you see it is irregularly irregular. So, this is your atrial fibrillation. This is your atrial fibrillation. Now look at this ECG. What are you seeing here? You are seeing this sawtooth pattern. Sawtooth pattern. This is your atrial flutter. Okay, this is your atrial flutter. Fine. So this is the approach to irregular tachycardias, irregular narrow complex tachycardias. You have your atrial fibrillation and atrial flutter. In both atrial fibrillation and atrial flutter, there is disorganized electrical activity. There is disorganized electrical activity. Okay, fine. Now let us go to the next one. The next type where the P waves are absent and you have a regular tachycardia. You have a regular tachycardia, then you are dealing with a paroxysmal supraventricular tachycardia, which can be your AVNRT and AVRT. We will be discussing this in detail further down, but just for the understanding, currently you have to know that a regular narrow complex tachycardia, right? So we are looking at narrow complex tachycardia, we are looking at absent P waves with narrow complex tachycardia. If it is irregular, it is either an atrial fibrillation or flutter, otherwise it is going to be a supraventricular tachycardia such as the PSVT. Now the PSVT can be an AVNRT or an AVRT and the rate is around 150 to 200 beats per minute. Fine. So let us look at this ECG here. Can you see that there are no P waves? There are no discernible P waves. If you just see here, this is a regular tachycardia. The QRS complex is narrow. Okay, QRS complex is narrow. But if you look closely, you can see that there are some P waves noted in lead 3. So this is your pseudo S waves in lead 3 and pseudo R prime waves in lead 1, which is your retrogradely conducted P waves. Okay, this is your retrograde conduction of the P wave, which occurs due to simultaneous atrial and ventricular activation because of the re-entry circuit. So there is simultaneous activation of the atria and the ventricle because of a re-entry circuit. So this results in a narrow complex tachycardia with retrograde P waves, So this is about your AVNRT. Then you have a junctional rhythm. A junctional rhythm basically comprises of a narrow complex rhythm which is arising from the junction with absent P waves, but the rate is usually less than 150 beats per minute. Okay, so that is about your narrow complex tachycardias. Now we are looking at broad complex tachycardias. So whenever the QRS complexes are broad, most often this is of ventricular origin. So if you see the ECG here, can you see broad QRS complexes? So there are broad QRS complexes with no P waves, So this is your ventricular tachycardia. So this is at a rate of around 200 beats per minute. When it is more than 250 to 300 beats per minute, it results in what is called as a ventricular fibrillation. Fine. So this is your brief approach to tachycardias on the ECG. So whenever you have a tachycardia rhythm, see if there is a P wave or not. If each P is followed by a QRS complex, it is your sinus tachycardia. If each P wave morphology is different, then it is arising from different foci in the atrium. So this is your multifocal atrial tachycardia. Now P waves are absent. The QRS complex is present and the QRS complex is narrow or broad. If it is a broad QRS complex, then we are dealing with a ventricular tachycardia. In rare cases, you can have an SVT with aberrancy, which is a broad complex tachyarrhythmia. In narrow complex, if the rhythm is irregular, it is usually a atrial fibrillation or an atrial flutter. If it is regular, you are dealing with an AVRT or AVNRT. And this is your junctional rhythm. Fine. So this is about how you approach tachycardia on the ECG. Now, let us look at the different types of supraventricular tachycardias. The first among them is your sinus tachycardia. Now, what do you mean by sinus tachycardia? You have already learnt that. That means that each P wave is followed by a QRS complex. Each P wave is followed by a QRS complex. Okay. And the P waves are upright in lead 2. So, where all can you sinus tachycardia? You can find it in fever, thyrotoxicosis, exercise, anxiety. Okay. The second one, what do you mean by inappropriate sinus tachycardia? What do you mean by inappropriate sinus tachycardia? So, we have already learned what is the cause of sinus tachycardia. Right. So, we have learned that fever, thyrotoxicosis, anemia, exercise, anxiety, any of it can cause sinus tachycardia. But in certain conditions, there will be a tachycardia in a patient unexplained, where there is no reason why he should be having tachycardia, but there is even at rest. So, this is what we call as inappropriate sinus tachycardia. And what is the drug that we give for inappropriate sinus tachycardia? You can give beta blockers, or you can even give ivabradine. Okay. So, the main symptom of this inappropriate sinus tachycardia is that they might have palpitations. Okay. But most often there is no reason for that, and you can treat it with a beta blocker or ivabradine. Right. Now, next type. The next type is your SART. This is a rare form of tachycardia. What does it stand for? This is your SA node. Okay. SA node, sinoatrial node reentrant tachycardia. This is your sinoatrial node reentrant tachycardia. Okay. So, what is the symptom of SART? The only symptom is that because it's a re-entrant circuit, it has a sudden onset and offset. Because it is a re-entrant circuit, it has a sudden onset and offset of this tachycardia. Okay, and patients are very, very symptomatic and they can have palpitations. Fine? Okay. Next, atrial tachycardia. Let us look at this atrial tachycardia. Basically means that the SA node, the impulse is cut the last line. This basically means that the impulse is not originating from the SA node, rather from some other focus in the atrium. That's why it is called as an atrial tachycardia. Now, can you just focus on the rhythm here? Now, you focus on the rhythm here. You have a P wave, QRS complex, T wave. So, you have a normal complex, normal complex. Now, can you see that the next expected normal complex would have been somewhere here? But what is this complex? This complex has arisen prematurely. Can you see that this complex is a narrow complex? Yes, this complex is a narrow complex. What is the morphology? It has a PQRS, but the P wave morphology is different from that of the sinus. So, this P wave morphology is different from that of the normal or the regular sinus. Right. So, the T wave morphology is different from that of the regular sinus tachycardia, or this is different from that of the normal sinus impulse that was expected. So, this is your PAC. This is your premature atrial complex. Okay. So, this means that there was a premature or an ectopic, atrial ectopic. There was a premature complex from the atrium. That is why the morphology is different from that of the expected sinus impulse. Okay. And this is usually followed by a pause. And this is usually followed by a pause, which is called as a compensatory pause. Right, because why is there a pause? Because then the ventricle goes into the refractory period until the next sinus impulse comes and it captures and goes on. Okay, so there is a pause because during that time there is a refractory period in which the ventricles cannot be excited until the next sinus impulse comes. Okay, So that is about your premature atrial complex. Premature atrial complex. Now, if there are more than 3 PACs occurring in a single row, then this is what we call as the atrial tachycardia. This is what we call as the atrial tachycardia. So, if there are more than 3 PACs which occur in a single row, this is what we call as the atrial tachycardia. Okay, fine. Now, what is multifocal atrial tachycardia? We have already seen that the atrial ectopics arise from different sides. And you have different morphology of P waves. And this is a narrow complex tachycardia. Okay, fine. Now, what is junctional tachycardia? In your junctional tachycardia, the junction, which is your AV junction, starts taking it up. So, not the SA node, not the atria, but the AV junction starts beating at its own intrinsic rate. So, will there be P waves? No, there are no P waves. What is the usual rate? The usual rate is 100 to 110 beats per minute, and it comes as a narrow complex regular tachycardia like this. Narrow complex regular tachycardia. Okay. Now, let us look at the next, which is nothing but your atrial flutter. Right. So, we have already seen in the approach to tachycardias that atrial flutter is because of disorganized atrial activity. Okay. It is because of a disorganized atrial activity. And is it a re-entrant circuit? Yes. We saw in the mechanisms of arrhythmias that this is a re-entrant circuit. What type of re-entrant circuit? This is a macro re-entrant circuit. Where does the re-entry take place? The re-entry takes place in an area which is called as the cavo-tricuspid isthmus. This is called as the cavo-tricuspid isthmus. So, can you see that this is the SVC and this is your tricuspid valve, and in between these two is your cavo-tricuspid isthmus, and that is where you have your re-entrant circuit. So, this re-entry is what results in a arrhythmia which is called as the atrial flutter. So, atrial flutter can be classified into two types as the typical flutter and the atypical flutter. Typical flutter and the reverse typical flutter. So, when the re-entry is in the anti-clockwise or the counter-clockwise direction, this is called as a typical flutter, whereas a reverse typical flutter is in the clockwise direction. Fine. So, what happens in your typical flutter? You have sawtooth waves. Yes, we have learnt that we have sawtooth waves. P waves are absent and you have sawtooth waves. If the sawtooth waves are negative in 2,3 AVF, it is your typical flutter. Whereas, if the sawtooth waves are positive predominantly in 2,3 AVF, here it is negative, then it is a reverse typical flutter. Fine. Okay. So, this is about your atrial flutter. Now, you would have also heard of something called as atrial flutter with like 3:1 AV block or 2:1 AV block, right? So, what does that mean? What does this 3:1 or 2:1 AV block mean, right? So, what is this? So, this means that the ratio means that how much of the atrial activity is being conducted to the ventricle, or where is the level of the block. For example, you are having a QRS complex, you are having a flutter wave, you are having a QRS complex, you are having a flutter wave. That means that this is a 2:1 block. Okay, what is a 3:1 block? You are having flutter waves, QRS complex, flutter waves. So this is your 3:1 block. So what does that mean? That every third complex is blocked. Okay, so flutter waves are, not all flutter waves are being carried forward for the activation of the ventricle. Alright, so that is about your atrial flutter. Okay, now how do you treat the patient? In an unstable atrial flutter, definitely you have to DC shock the patient. That means you will have to do a cardioversion. Okay, you will have to do a cardioversion. In stable patients, the drug of choice would be an ibutylite. The stable patients, the drug of choice would be ibutylite. If it is not available, you can give amiodarone as well. Okay, so this is about your atrial flutter. Fine. So I hope you have understood what is atrial flutter. Now let us move on to the next type, which is your atrial fibrillation. Okay. So what is your atrial fibrillation? You see from this ECG there is an irregular rhythm, right? So there is an irregular rhythm. The P waves are absent. And you have F or fibrillatory waves. Okay, you have fibrillatory waves. So there is complete disorganized electrical activity in the atrium. So what is the etiology? Most of the times the etiology of atrial fibrillation remains idiopathic. Ischemic heart disease. In ischemic heart disease, if they have had a huge MI and the LA has become thinned out, then what happens is that the stretching of the LA causes a lot of electrical instability, and this can result in a run of atrial fibrillation. We have already learned from the discussion on valvular heart diseases, whenever there is massive left atrial stretch, this can happen in multiple valvular heart diseases like MS. MS is associated with atrial fibrillation. MR is associated with atrial fibrillation. Cardiomyopathies like HOCM, MS, MR, HOCM, all of these are associated with atrial fibrillation. Okay. Then infections can trigger atrial fibrillation. Sepsis, right? A patient with sepsis who is admitted in the ICU can have AF. Okay, because age in itself is a risk factor for AF. Right? So, old patient who is admitted with respiratory complaints or infections, hospitalized patients are at a high risk of atrial fibrillation. Respiratory infections and respiratory conditions like COPD are associated with multifocal atrial tachycardia, even atrial fibrillation. Fine. Then renal dysfunction and uremia can trigger AF. Endocrine dysfunctions like thyrotoxicosis, very important. You treat the underlying condition, thyrotoxicosis and the AF improves. Then toxins, which toxins? Mainly alcohol. Alcohol associated AF is called as holiday heart syndrome. Alcohol associated AF is called as holiday heart syndrome. Okay, so that is about the toxins, and also never to forget dyselectrolytemia. So any form of dyselectrolytemia, sodium disorders, potassium disorders, all of these can trigger atrial fibrillation. Fine. So that is about the etiology of atrial fibrillation. Now, what about the classification? So atrial fibrillation can be classified as valvular and non-valvular AF. So what is the meaning of this? We have briefly seen this in our chapter on mitral stenosis. So what is the meaning of valvular AF? So the AF which is associated with mitral stenosis, is called as valvular AF. The AF which is associated with any other valvular heart disease is not referred to as valvular AF. Always remember that. So if you have an MR with AF, it is not valvular AF. The AF which is associated with mitral stenosis alone is called as valvular AF, and any other form of AF is your non-valvular AF. Fine. Why do you need this classification? Because the treatment varies. We use only warfarin for the treatment of valvular AS. There is no role of NOACs. What are NOACs? NOACs are novel oral anticoagulants, which includes your dabigatran, rivaroxaban, apixaban. So these cannot be used in your valvular AF. Fine. So that is the reason why you need to know about valvular AF. So depending upon the duration, it can be classified as paroxysmal AF, persistent AF and permanent AF. Paroxysmal AFs are those AF episodes which basically last for less than 7 days. Okay, so paroxysmal AFs are those atrial fibrillation episodes which last for less than 7 days. Persistent AF is defined as that which lasts for more than 7 days. Okay, and permanent AF is that which is lasting for more than a year. Fine. So that is your paroxysmal, persistent and permanent AF. Look at the clinical features. Now let us look at the clinical features. Now atrial fibrillation can give rise to a sense of dyspnea. They can also complain of palpitations. Palpitations are usually irregular palpitations. So these are irregular palpitations. Then there can be angina. So AF can be associated with some amount of anginal pain because there is decreased coronary blood flow, because of the decreased coronary blood flow whenever they have the episodes. The endocardial flow can also be reduced, and that's the reason why they can have angina. Some patients can also complain of pre-syncope. Fine. So that's about the clinical features. Now let us look at the management. So till now what all have we learned? We have learned about what is AF, how do you identify AF on the ECG, what are the etiologies and the classification of atrial fibrillation and the clinical features. Fine. Okay. Now let us look at the management of AF. Now management of AF depends on whether there is an acute atrial fibrillation or a chronic atrial fibrillation. Fine. So this depends upon whether there is an acute atrial fibrillation or a chronic atrial fibrillation. In acute AF, if the patient is unstable, then you have to do a cardioversion. Fine. You have to deliver an electrical shock. So what do you mean by an unstable patient? Unstable patient means the BP is less than 90 millimeters of mercury. Okay, patient is having hypoxia, patient is having heart failure, not a chronic heart failure, acute. Acutely he has gone into failure, suppose because of the arrhythmia, or the patient is having an altered mental status. So if the patient is having an altered mental status, then in an unstable AF you will have to do a cardioversion. Stable AF. Now let us say there is a young patient who has come with no comorbidities. There is a young patient who just walks in, who has come with no comorbidities, and he has been saying that I have been having some palpitations from the past 1 week, or let's say from the past 3 to 4 days. Okay, so you examine him, on the pulse you find an irregular rhythm. Now you suspect he is having an atrial fibrillation, you send him for the workup, which includes an ECG and an echo. ECG is showing AF, echo is not showing anything. And you do the entire panel and you rule out any reversible causes such as electrolytes, renal functions, liver functions, and any other reversible cause is looked into. Okay, now you have not found anything, and what do you determine it as? Most of the time the AF will be a paroxysmal AF. Okay, most of the time it is a paroxysmal AF. Okay, so if this is a paroxysmal AF, then if it is lasting for less than 48 hours, you just treat the patient with a beta blocker. Okay. Now, in hospitalized patients, the patient is still stable. He is admitted for some other reason, like he is admitted for COPD, he is admitted for some sepsis. So, this is precipitated by a temporary event mainly just his illness has precipitated the atrial fibrillation. Then if this is been for less than 48 hours, then you directly give them a rhythm control agent. You directly give them a rhythm control agent such as IV amiodarone. Okay. If it is more than 48 hours, you have to do what? You have to do a transesophageal echo. Why? Because in every atrial fibrillation which has been there for more than 48 hours, there is a risk of thromboembolism. Why? So, what happens is that in the LA there is something called as the left atrial appendage. In this left atrial appendage, what happens is that there is stasis of blood. There will be stasis of blood. So, whenever there is pooling or stasis of blood, this has a risk of formation of clots. There is a risk of formation of clots. So, what happens is that the next time that the patient has an arrhythmia, this clot can break. And it can pass through the arterial stream and embolize to different parts of the body. So, there is a risk of stroke. That is the reason why if this AF has been going on for more than 48 hours, do a transesophageal echo, look for a clot. Because if you directly go and give them a drug which is going to put it back into sinus rhythm, then there is a huge risk of embolization and a huge risk of stroke. Right? So, if the clot is negative, then you do a pharmacologic cardioversion. With the help of an antiarrhythmic drug. But if there is a clot, then you will have to anticoagulate the patient for 3 weeks. Then you do your pharmacologic cardioversion and continue the anticoagulation for 1 month. Because the stasis in the left atrial appendage can take up to 1 month to recover. The stasis in the left atrial appendage can take up to 1 month to recover. That is the reason why if the atrial fibrillation in a hospitalized patient or in a acute AF is lasting for more than 48 hours, you do a TEE, rule out a clot. If there is a clot, you have to anticoagulate the patient, then give your antiarrhythmic drug. So, what are the drugs which are used for? Pharmacological cardioversion? You have your class 1C drugs, flecainide, amiodarone, vernacalent, imudal. Flecainide, amiodarone, vernacalent and ibutylide. Vernacalent out of this is your fastest acting and this is a potassium channel inhibitor. Okay. So, that is about your management of stable acute AF. Okay. So, I hope you have understood till here. Now, what is this pill in the pocket approach? So, pill in the pocket approach means that in those patients, in young patients with no comorbidities, in young patients with no comorbidities, patients having paroxysmal AF, what you can do is that if you have ruled out all the reversible causes, thyrotoxicosis, electrolyte imbalance, or echo is not showing any evidence of structural heart disease, then you can give them a pill. Most often it is your ibutylide with a beta blocker. Okay. So, what happens is that this can be kept in the pocket in the sense that whenever they feel the palpitations, this drug can be taken and it will arrest the atrial fibrillation. So, this is what we call as the pill in the pocket approach. So, this pill in the pocket approach is not done for everybody. It is done for young patients with no comorbidities and if they have a paroxysmal AF. Alright. So, what is the role of anticoagulants in acute AF? In acute AF, there is generally no role of anticoagulants. Though in our clinical practice, we do put the elderly also on anticoagulants because we do not know whether this is a persistent AF or a permanent AF, right? So, most of the time, if you are sure that this is an acute AF, okay, and it's a paroxysmal AF, then there is no role of anticoagulants. Fine. So, during an acute AF, there is no role. Once the AF has settled, you calculate the Chad-Vas score, and if there is a chronic AF, then you anticoagulate them. Okay? Fine. So, that is about the management of acute atrial fibrillation. Now, let us move on to chronic AF. Let us move on to chronic AF. The management of chronic AF, there are 2-3 things that you have to look into. One is you have to anticoagulate the patient, because just now we had discussed that AF is associated with an increased risk of embolus and thromboembolism. That's the reason why you need to anticoagulate the patient. The second thing is you have to determine the strategy which you want to use, whether it's a rate control or a rhythm control strategy. Okay. Let us look at anticoagulation. In anticoagulation, in deciding the anticoagulation, the score that we use is called as the Chad-Vas score. The score that we use is called as the Chad-Vas score. So, what do we do in this Chad-Vas score? C stands for congestive heart failure, H is for hypertension, A is for age more than 75, which is given a score of 2, all the others are given a score of 1. D is diabetes, S is given for stroke, which is given a score of 2. V is vascular, age is, there are 2 ages, remember, in this Chad-Vas score, age more than 75 and age is 65 to 75 years of age, and S is for the female sex. If the score is more than 2, then you have to definitely anticoagulate the patient. So, if the Chad-Vas score is more than 2, you have to definitely anticoagulate the patient, and most often this is your lifetime anticoagulation to prevent a stroke. Okay, fine. Okay. Now, in valvular AF, what will be the anticoagulant of choice? Just now we have discussed, it is warfarin. In non-valvular AF, what will you give? You will give dabigatran, right? It is dabigatran, or you can give apixaban or rivaroxaban. Okay, apixaban is more preferred in elderly, okay, and in renal failure. In elderly and renal failure, apixaban is more preferred. Now, let us look at the strategy that can be used. So, we have the rate versus the rhythm control. So, in which patients will you prefer a rhythm control strategy? So, in patients with paroxysmal AF, you will prefer a rhythm control strategy. If the age is less than 65, there is no hypertension, there is lesser LA size, means no comorbidities, and not much of a atrial dilatation, and recurrent symptomatic persistent AF, you prefer a rhythm control strategy. So, which are the drugs used? We have just now discussed amiodarone, flecainide, vernaculant, ibutaline. Okay, but if there is a patient with a structural heart disease, right? You can give amiodarone. Amiodarone is preferred in a structural heart disease, but you prefer a rate control strategy with what? With beta blocker or calcium channel blocker. So, in an elderly with multiple comorbidities, or if they are having a structural heart disease, we prefer a rate control strategy. Okay. So, that is your rate versus your rhythm control for management of chronic atrial fibrillation. Now, if it is not working with this drug also, there is no sinus rhythm, then you will have to go ahead and do a catheter ablation. You will have to go ahead, do an EPS study and do a catheter ablation. Now, there are also some surgical procedures that can be used in the management of atrial fibrillation. The surgical procedures are, one is your Watchman device. So, what is a Watchman device? I told you that the left atrial appendage is where the clots are formed most because of the stasis of blood. So, you put a device here which occludes this and prevents the movement of the clot. So, this occluder is what we call as the Watchman device. So, Watchman device occludes the left atrial appendage and prevents the clot from going out. Okay. Then we have another procedure which is called as a Cox-Maze procedure. So, we know that we know that what happens in atrial fibrillation? There are multiple foci in the atrium. So, we do a procedure where we create multiple scars throughout the atrium such that the atrial fibrillation gets ablated. So, this is what we call as the Cox-Maze procedure. So, this Cox-Maze procedure is not performed frequently, but this is one of the surgical procedures that can be used in the management of atrial fibrillation. Okay. So, this was a huge topic. We have learned about atrial fibrillation. So, what all have we learned? We have learned about the ECG findings, etiology, classification, clinical features, management of acute and chronic AF. Okay. So, now we will move on to the next group of supraventricular tachycardias, which is your AVRT and AVNRT. Okay. So, first we will start with the AVNRT. So, the 60% of paroxysmal supraventricular tachycardias. I told you that supraventricular tachycardias means that there will be an origin above the ventricle, which includes the atrial arrhythmias as well. But PSVT is mainly used as a term for this AVRT and AVNRT. So, 60% of the paroxysmal supraventricular tachycardias are due to AVNRTs, and it is more common in women. It is more common in women. Okay. So, what is the meaning of this? This stands for AV node re-entrant tachycardia. So, what is the mechanism? We have already learnt the mechanism that there is a re-entry circuit in the AV node. So, let us understand that. Normally the AV node has two pathways. It has a fast pathway and a slow pathway. Slow pathway basically means that it is slow to depolarize or conduct, and it has a longer refractory period. Okay. So, let us look at how the normal impulse is conducted. So, normally the impulse comes down like this and moves down the fast pathway. Now, there is another impulse which will be coming down the slow pathway. But since the impulse which is coming down the fast pathway goes fast and it comes and negates this impulse which is coming down the slow pathway. It negates the impulse that is coming down the slow pathway and conducts downward to the ventricle. Right. So, this is the atrium side, this is the AV node, and this is the ventricle. Right. So, there are usually in a normal person there can be two pathways, a fast pathway and a slow pathway. A slow pathway is slow to conduct and it has a longer refractory period. So, a normal impulse which is coming from the atrium goes down the fast pathway first and it can go down the slow pathway. But this is negated because the impulse coming down the fast pathway negates the impulse coming from the slow pathway and further continues down and stimulates the ventricle. So, there are no two impulses, there is one impulse which gets conducted from the atrium to the AV node to the ventricle. Okay. So, this is normal. Now, what happens? In AVNRT? Okay. So, what happens in AVNRT is that again this is your normal impulse which is coming down your fast pathway and goes up the slow pathway. Okay. This is your normal impulse and it will be negating here. But there can be an ectopic impulse. Now, what happens when this ectopic impulse is there? The ectopic impulse that comes here starts going down the slow pathway, but it cannot be negated because at that time the fast pathway will be in its refractory period. So, what happens is that the ectopic impulse which is produced here, so there is an ectopic impulse that is produced. This ectopic starts moving down like this and it cannot be negated and then it undergoes a re-entry. So, what happens is that there is a cycle that is created because of this ectopic. So, it comes down the slow pathway and it goes up the fast pathway like this. So, it comes down the slow pathway and goes up the fast pathway this way. Okay, so it results in a cycle. So when this happens, it causes simultaneous activation of what? Simultaneous activation of the atria and ventricles. It causes simultaneous activation of the atria and ventricles. And this is what results in your PSVT. So this is what results in your AVNRT. Okay, we got it. So this is about your slow and fast pathways. In a normal individual, the impulse that comes down the fast pathway negates the slow pathway impulse. But in AVNRT, what happens is that there is an ectopic. Because of the ectopic, it comes down the slow pathway and it's carried up the fast pathway, because at that time the fast pathway is in its refractory period. So the impulse comes down the slow pathway, goes up the fast pathway and enters a re-entrant circuit, causing simultaneous activation of the atria and the ventricles. Fine. So that is about your mechanism of AVNRT. Right. So let us look at the ECG findings. What are we seeing here? We are seeing a narrow complex tachycardia. Right? Why are we saying this is a tachycardia? Can you see the heart rate? What is the heart rate? Heart rate is about 300 by 2 large boxes, around 150 beats per minute. This is a narrow complex tachycardia. Are there P waves? No, P waves are not seen. But you can see some amount of pseudo R prime waves in V1 and some S waves kind of thing in lead 2. Can you see that? So this is nothing but your pseudo R prime waves in V1 and pseudo S waves in lead 2. We have pseudo R prime waves in V1 and pseudo S waves in lead 2. This is because of your retrograde P waves. This is because of your retrograde P waves, and this is your ECG of AVNRT. AVNRT. Okay, this is the ECG of AVNRT. So we have understood till here. What will be a typical AVNRT and what is an atypical AVNRT? What is a typical AVNRT and what is an atypical AVNRT? A typical AVNRT will be when there is a flow through down the slow pathway and up the fast pathway. But if the electrical activity is in the counterclockwise direction, then it is a atypical AVNRT. Okay. So that is about your mechanism and ECG of AVNRT. So that is about your mechanism and ECG of AVNRT. We will be coming to the management of supraventricular tachycardias and clinical features together. Now let us look at the next type. Let us look at the next type. The next type of re-entrant circuit is your AVRT. So this stands for atrioventricular. This stands for atrioventricular re-entrant tachycardia. Atrioventricular re-entrant tachycardia. So as you can see from this line diagrams that the re-entrant circuit is between the atrium and ventricle. Okay, so it is much larger and you can see that this can be mapped on the EPS study and this is called as a macro re-entrant circuit. So what are the two types? The two types are orthodromic and antidromic AVR. Okay, so what happens here is that congenitally itself they can have a pathway which is called as the accessory pathway. So congenitally itself you can have a pathway which is called as the accessory pathway. Okay, so what happens here is that the normal impulse comes down from the atrium to the ventricle and it goes up the accessory pathway. So it causes simultaneous activation of the atrium and ventricles again. So this is what we call as the orthodromic AVRT. But there can also be an antidromic AVRT where the impulse comes down the accessory pathway, and goes up the normal pathway. It comes down the accessory pathway and goes up the normal pathway. So this what happens is that this results in a wide complex tachycardia. Right? So orthodromic Orthodromic AVRT results in a narrow complex tachycardia. Antidromic AVRT results in a wide complex tachycardia. So, I hope you have understood till here. So, if it comes from the atrium to the ventricle and goes up the accessory pathway, it is orthodromic. If the impulse comes down the accessory pathway and goes up the normal pathway, it is antidromic. Okay. So, the most common association of AVRT is your Wolff-Parkinson-White syndrome. Okay. It is your Wolff-Parkinson's White syndrome, right? So, this is a congenital or a genetic condition characterized by the presence of an accessory pathway. And which type of AVRT is seen here? This is your antidromic AVRT. This is your antidromic AVRT which is seen with WPW syndrome. Fine. So, what are the characteristic ECG findings? The characteristic ECG finding is what we call as first the delta wave. Okay. So, the presence of this accessory pathway, what happens is that the QRS complex has a initial slurred portion and this is what we call as the delta wave, and the QRS complex is definitely wider. Okay. So, this is a narrow complex tachycardia with absent P waves but a wide QRS complex in antidromic AVRT, and the initial slurring is called as a delta wave. Apart from that, you can have a short PR interval. So, it's very, very important, because if there is a short PR interval, then this definitely means that they are predisposed to more severe form of arrhythmias. Then, what are the other ECG findings? You can have QRS alternance and cycle length alternance. Okay, let us understand that with the help of this ECG. So, what can you see here? You see a narrow complex, regular tachycardia. Okay. So, you see a narrow complex regular tachycardia. What can you see here? You can see that there is some slurring of the QRS complexes initially. There is some slurring, right? So, this slurring is what we call as the delta waves. Can you see it here as well? Fine. Then, what happens to the QRS complexes? Can you see that the QRS complexes are moving like this? Right, so they are going like this. This is because the QRS complex becomes taller, larger, and so on. This is what we call as the QRS alternance. Okay, and we also have a cycle length alternance. So, some of it are of different cycle lengths. So, these are the characteristic clinical features that you find in your AVRT. Okay. What are the clinical symptoms? What are the symptoms that the patient can present with? So, the patient will complain of palpitations. What type of palpitations? They will complain of regular palpitations. Okay, they will complain of regular palpitations. They will have a pounding sensation in the neck. You will have a pounding sensation in the neck. So, why is that so? This is because of the presence of Canon A waves on the JVP. So, what are Canon A waves due to? You will recollect from the class on JVP that when the atria contracts against a closed ventricle. So, when the atrium contracts against a closed ventricle, this results in Canon A waves, and this Canon A waves is seen as a pounding sensation in the neck, and this is what we call as the frog sign. This is what we call as the frog sign. Okay. So, these are the basic symptoms which they can present with. Sometimes because of the palpitation, they can also feel lightheadedness. Okay. So, that's about the symptoms. Now, let us move to the management. So, the management of AVNRT and orthodromic AVRT. the management of AVNRT and orthodromic AVRT. So, in an unstable patient, we do a DC cardioversion. So, what do you mean by unstable? So, in an unstable patient means what? The BP is low, right? The patient is in shock. There is hypoxia. There is altered mental status. Right? So, the patient is unstable. So, the BP is low, there is hypoxia, there is altered mental status, then you do a DC cardioversion. In a stable patient with PSVT, we do vagal maneuvers. What do you mean by vagal maneuvers? You basically do a carotid sinus massage. And this will help you to slow down the rate, and in fact it will also help you to arrest the tachyarrhythmia. If vagal maneuvers are not helpful, then you go ahead and give the drug of choice is adenosine. So, how is this adenosine administered? They are administered as a 6 mg bolus dose. It is administered as a 6 mg bolus dose. Remember that this has a very short T-half. So, the half-life is in fact even less than 30 seconds. So, it is better to administer adenosine as a IV push, as a IV bolus, fast bolus, and with the help of a peripheral vein which is more closer to the heart if possible, or you raise the patient's arm immediately above the head after administration of adenosine. Always warn the patient that there can be a sensation of impending doom. It's a very uncomfortable sensation while administering adenosine. So, there can be a sensation of impending doom. Right? Okay. If 6 mg does not work, you give another 12 mg. If 12 mg does not work, you give another 12 mg. Now, if adenosine is not at all working, then always remember it is better to treat. Always remember that it is better to treat as a VT, and you give amiodarone. Okay, so if you are having a doubt with the ECG, or if any of this is not working, then always treat the SVT as a VT and give them amiodarone. What is the most important contraindication? What is the most important contraindication to adenosine? It is the presence of bronchospasm. Okay, it is the presence of bronchospasm. So, that is about your management of AVNRT and orthodromic AVRT. Now, we come to the management of Wolff-Parkinson-White syndrome or antidromic AVRT. So, what happens in this Wolff-Parkinson-White syndrome or antidromic AVRT is that there is a pre-excitation. Pre-excitation means that the impulse travels down the accessory pathway. And goes up the normal pathway. Right? So, in these kind of patients, if you give a AV nodal blocking agent, okay, in this kind of patient, when you give a AV nodal blocking agent, what will happen? This will get blocked, right? This will get blocked. But what happens to this impulse here? This impulse can continue to come down the accessory pathway. It can continue to come down the accessory pathway and cause stimulation of the ventricles. Also, especially in the case of pre-excited atrial fibrillation, it is very, very difficult to know. In that, you might end up giving an AV nodal blocking agent. Then this can stimulate the ventricles and result in a fatal VT or VF. Okay, it can result in a fatal VT or VF. That is why it is contraindicated in WPW syndrome. So, the treatment for this would be best an ablation. The treatment best would be an EPS study and ablation of the pre-excitation. Okay. So this brings us to the end of the chapter on supraventricular tachycardias and your PSVTs. Okay, so in the next chapter we will be discussing about ventricular tachycardias. Thank you.